right, thank you, and I'm happy to be here to talk about some of the developments with newborn screening for critical congenital heart disease, CCHD, recently recommended by the Secretary of Health and Human Services to be added to the Uniform Newborn Screening Panel. So first, I just want to talk about the federal role in implementing screening for critical congenital heart disease, some of the state activities going on with screening for CCHD, and to talk about a survey of birth defect surveillance programs that we undertook at the CDC working with the National Birth Defects Prevention Network. I'm really going to be focusing more on what CDC is doing. There's a lot going on, but that is who I'm representing here. So in 2010, September, the Secretary's Advisory Committee on Heritable Disorders in Newborns and Children voted to add CCHD to the Uniform Newborn Screening Panel. And when the advisory committee recommends, it goes to the secretary, and then the secretary has a certain amount of time that she can require more information, make a decision. So it's really, they can recommend, but it's really up to the secretary to decide whether or not she's going to take their recommendation. And after a year, with some thought and consideration, the secretary did approve adding CCHD to the Uniform Newborn Screening Panel. So along with this approval came some recommendations or requirements for the different federal agencies to help states, help the federal government implement this recommendation. So screening standards and infrastructure need to be developed. HRSA is to guide the development of screening standards and infrastructure. HRSA recently funded states to begin implementing CCHD, and a lot of what those states are going to be doing through those grants is to develop the standards and infrastructure. There needs to be education and training. HRSA is to fund the development of appropriate education and training materials. The FDA is providing guidance to industry and FDA staff on pulse oximeters. Pulse oximeters are the current technology that are recommended to detect and screen for CCHD, measuring the oxygen level in the blood of newborns. It's a tool that people are used to using, hospitals are used to using it, but this is applying it to a non-standard application. It's used for measuring blood oxygen levels. It's not meant for screening a condition. And so the FDA really has to apply standards to that, work with the different companies to develop those. Research needs to take place. The NIH is to determine the screening technology, diagnostic processes, care provided, and health outcomes. And then surveillance, public health surveillance is a part of this, and CDC is to monitor infant mortality and other health outcomes, clinical utility, and program evaluation. I'm going to focus specifically on what CDC is doing, what CDC has been doing to talk about CDC and birth defect surveillance and how it pertains now to newborn screening for critical congenital heart defects. So, one of the main things that CDC does, it's really our bread and butter activity, is to evaluate state surveillance and tracking. And to do this, we worked with the National Birth Defects Prevention Network, otherwise known as NBDPN, to do a survey of states and their surveillance programs to see how they felt they could help states implement CCHD newborn screening. And I will get into that in a little more detail after this. We've also been working with states to do what we call an EPI-aid. An EPI-aid is when we send EIS officers, our Epidemiology Intelligence Service officers, to a state to help them. Typically, you think about them with food outbreaks or other infectious disease, but when the opportunity comes to do something a little more chronic, birth defect surveillance or newborn screening, we're really pleased for the opportunity. And my EIS officer, Jill Glidewell, and our Prevention Effectiveness Fellow, Cora Peterson, went to New Jersey in January and February to assist New Jersey with an EPI-aid and Econ-aid of their rapid implementation of CCHD newborn screening. We are also currently working with Georgia. Elizabeth Ailes is a newer EIS officer working in our center, and she and some other fellows have been working with Georgia to do a similar type of activity. We are going to conduct, or we have been conducting, a cost-effectiveness analysis of CCHD screening. Like I mentioned before, collaborating with New Jersey and Georgia to do an econ aid to assess total cost burden, and ongoing evaluation activities using existing surveillance data that we have. One of the things we'd like to do, and it's a little trickier, but people are working on it, is to leverage the electronic health record framework to be able to collect data with CCHD. And our center has a working group on electronic health records. We've been creating a strategic plan for using electronic health records. I know they're doing this with birth defect surveillance, and they really want to focus on congenital heart defects in general, not just the few congenital defects that are considered critical. And we are going to collaborate, or are collaborating, with the National Library of Medicine to harmonize surveillance codes with the newborn screening codes. So one of the things is just to show you how activities have changed with newborn screening. This is a map that was developed by the Newborn Coalition, and like Dr. Cantor was saying, simply because something is recommended on the Uniform Screening Panel does not necessarily mean that states are ready and able and willing to start working on it. But there has been a lot of activity with CCHD. In green, so green, you have legislation passed. So you can see the number of states that introduced legislation in this last year and passed that legislation. States where legislation was introduced but perhaps did not make it, through the state legislature. I can speak to Georgia. Georgia introduced legislation to simply set up a work group to look at CCHD, and that's what a lot of these states are doing. They haven't necessarily implemented it, but through their legislation, they are putting up a work group, looking at the problem, talking about how they're going to do it. Georgia introduced it. It did not pass just for some quirky legislation things, but Georgia still is continuing to go ahead, even without the legislation, saying we want a work group. They have invited CDC to help them with an epi aid and an econ aid, so there is a lot of interest in moving forward. And then some states have legislation pending. Those are the light blue. We've got states with multi-center screening or pilots, and then there's some states that just haven't taken any action, and they may or may not. I mean, this is a recommended panel. It's not a required panel for states to do that. And a lot goes into a state deciding whether or not they want to do something. This is just a state really giving a little more. This is from the American Academy of Pediatrics. Very recent, as of May. It's still good as of June, where legislation has been enacted. Legislation introduced in blue, enacted in red, and executive order. It's not even going through the legislation. The governor has decided that there's going to be some kind of action on CCHD. So it's just been recommended, but there has been a lot of interest among states and a lot of growing activity. So CDC has been involved with birth defect surveillance for many years. I mean, based in Atlanta, we have the Metropolitan Atlanta Congenital Defects Programs, one of the first birth defect surveillance programs in the United States. So they have a history of collecting data, developing case definitions, using that data then to analyze trends, look for ways that you can improve outcomes or initiate prevention if that's necessary. So, I mean, here we are talking about newborn screening for something that we typically think about as birth defects. How can a birth defect surveillance program be helpful in either tracking or evaluating the program? Birth defects and newborn screening are very different animals. The purpose is different, they think differently, their time frames are differently. So it's not, you've got two public health programs that are involved in finding, tracking children, looking at outcomes, but they have slightly different approaches. But we did want to know, how can birth defect surveillance programs be of use? So through the National Birth Defects Prevention Network, which is a not-profit organization of birth defect surveillance programs in the country, we distributed a survey just to ask them, what do you think about this? Where do you think this might take place in your state? How do you see your role? What are some roadblocks that you may see? That data came in, and we looked at it, but quite frankly, we didn't really do anything with it. And then in the following year, the Secretary approved it, and we thought, well, let's just look back with these states and see what they've done. Have there been any changes? Would they answer any of these questions differently now that the Secretary has actually approved it? And if so, maybe we can get a little more information out of them. So states were asked to confirm or change responses from 2010. So first of all, does your state have a birth defect surveillance program? And most of them do, but not all of the states have a birth defect surveillance program. So first we just wanted to get that, that base level there. So 43 states have a birth defect surveillance program. And is your state engaged in pulse oximetry screening for CCHD? Engaged can be anything from setting up a task force or work group to look at CCHD and examine the issue to, yes, we are actively conducting it or we have passed legislation. So this is really a broad question. But if you look at that comparison between 2010, which is in the dark blue, and 2011, in 2010, only one state said, yes, we are engaged in pulse oximetry screening for CCHD, and then in 2011, that increased to 10. 10 states were engaged. The number that were not engaged in 2010 was 30. That dropped to 21 states in 2011. In 2010, 12 states said, we don't know. We don't know what our state is doing about CCHD. And their uncertainty has dropped within a year. 3 states now say we don't know what our state is going to do about CCHD. And when some states say, we don't know, or, it could be that the plans haven't been set yet. But at any rate, what this shows is that states are thinking about CCHD, they are engaged in it, and they are coming up with some way of approaching it. So if your state is engaged in screening activities, and keep in mind this is, how many was that? 10 states. So if you are engaged in the activities, is the screening universal statewide? 4 states said that this was universal statewide newborn screening that they were either doing or planning. For 1 state, it was going to be regional. We also want to know, is this going to be hospital-based, or are you taking this out into other birthing centers? 9 of the states said this will be hospital-based CCHD, pulse oximetry screening, and 1 state said that it was going to be other. So that would be expanded to take into account other birthing centers outside of hospital-based. If your state is engaged in screening activities, what components are included to that? The state is screening only, which means that when the state legislation went into place, they really were just specifying that newborns are going to be screened. They didn't necessarily talk about what the follow-up of positive screens was going to be, or whether or not there was going to be data collection or any kind of tracking. So 4 of the states are doing screening only. 5 states have screening and follow-up of positive screens, and then 3 were other. So there could be some, birth defect collection or other data follow-up going on. If your state adopts newborn screening for CCHD, how could birth defect surveillance program assist with the confirmed cases of CCHD? And so these are possible options for assistance. We had a list of likely options, and then the number of states that selected that. Link children identified by screening to support services, and 16 states said that was what they would do, and that's really a big function of birth defect surveillance, is to make sure that the kids are linked into support services and follow-up services. They could report on healthcare utilization by affected children. They could report on support services utilized by affected children. They could report on the enrollment of affected children into special education services. This is a type of analysis that's been done through our center, working with states, where you can actually link to special education databases for school-age children and check and see how children with birth defect surveillance are utilizing special education services. How could the birth defect surveillance program assist with evaluation of CCHD newborn screening? Evaluate mortality with CCHD, evaluate what morbidity is associated with CCHD. This is what birth defect surveillance programs do. Are the kids alive? How are they doing? What do they have? And they do it through case ascertainment with either trained abstractors or set standard definitions where people can submit data. Evaluate the interventions associated with CCHD. What services did these kids develop? Evaluate all true and false positive screens, evaluate false negative screens, and assist with the economic evaluation of screening. We want to know, where people are located. Are you working with the newborn screening program? And like I said, these are not necessarily the same animal. They can be very different. They don't necessarily talk to each other. But some of them are located together. 11 states reported that. They're contained within the same Bureau of Program. They're physically located in the same building, which is excellent, that you could actually walk down the hall or walk up a floor to see somebody, sharing the same database. Some have none or no working relationship. This will be a challenge because sometimes you actually have to have a state law or legislation put into place to be able to talk to each other. And the barriers then would be lack of legislative, regulatory language or authority to either collect that data or to work with newborn screening, inadequate staffing, insufficient funds, needing that information technology or data linkage needs, and other. So they have surveillance programs. They have the data that can be used to evaluate the implementation of CCHD, the availability to tell how kids are doing, what services they have needed. There is real opportunity for collaboration between state newborn screening and birth defect programs, not just with CCHD, but with any other newborn screening programs that may come down the pike, 22q deletions, et cetera. But there are barriers. So at any rate, just to follow up, I just reported this survey. We have this written up. We've submitted it to CDC's MMWR. It is in revision, so we hope maybe by the end of the summer we should have that in MMWR. The data from the New Jersey Econ Aid, cost burden to hospitals, has been written up. They are planning the submission to American Journal of Managed Care. There's another cost-effective analysis, I think, which is using possibly Florida birth defect surveillance data, planned submission to pediatrics, the New Jersey EpiAid, where Jill collected the information about their readiness for data collection and submission and epidemiology of case detection, written up a planned submission to MMWR, but New Jersey would like to also have their paper on cases. And then a data report coming up in in December, Birth Defects Research Part A, where they're going to actually be starting to publish standard data on CCHD. There's the collaboration with Florida Birth Defects Registry, hospital cost and timely detection, factors associated with late detection of CCHD. And then we also have a large case control study that CDC funds, and they're also looking at late detection of CCHDs, assessing the impact of newborn screening. So what impact could newborn screening have? Just to acknowledge the people that I work with at CDC and the other networks and programs, and thank you. And I don't know if there's any time for questions or not, but I'd be happy to entertain any questions that people have. Okay, thank you.